Welcome to this session of the Center of Podiatric Education. In this discussion, I'd like to review a topic that involves many podiatric physicians in primary care practice, and that's the subject of treating onychomycosis in the geriatric patient. This is something that has long been a part of podiatry and can be an important part of our practice. And I'd like to discuss current concepts and principles, where we've been and where we're going. We know that onychomycosis is common in the geriatric patient, and we know that most commonly it is caused by dermatophytic fungi, statistically most often T. rubrum, less commonly T. mentagrophytes, and it's more common in men than it is in women. We see various estimates regarding onychomycosis in the older patient. It's been suggested that it can affect between 50 and 70% of patients over the age of 65. However, if we look at patients who actually go to the office of a provider for the evaluation of a toenail problem thought to be fungus, that as many as 90% of patients will in fact demonstrate onychomycosis, with T. rubrum overwhelmingly the most common infecting organism. There are various presentations of onychomycosis. There is superficial white onychomycosis, distal lateral subungual onychomycosis, dystrophic onychomycosis, proximal white onychomycosis, and really it's, I think, helpful to include in the medical record the clinical presentation type. Distal lateral subungual onychomycosis typically is the clinical form affecting the great toes, whereas we oftentimes see the lesser digits with superficial white onychomycosis. Again, we see various estimates regarding nail changes and the actual incidence of onychomycosis. Others have suggested that about half the time abnormal appearing nails are onychomycosis. And while there's a broad range of differential diagnosis, from a practical standpoint, onychomycosis and repetitive mechanical trauma from impaction of the nail into the shoe is probably representative of the most common differential diagnosis. We certainly want to keep in mind other disorders such as psoriasis or lichen planus, but certainly with the great toe, dystrophic and distal lateral onychomycosis are the most common presenting forms, and distal lateral, or rather a superficial white onychomycosis, and distal lateral subungual onychomycosis, the most common forms affecting the lesser digits. Now, the geriatric patient generally responds slower to therapy, and I think it is important when discussing therapy with the older patient to let the family and the patient know that it is important to treat this disorder. However, response will be slower. There may be the effects of associated nail trauma, for example, a hyperextension deformity with hallux limitus and resultant repeated nail impaction. We have slower growth of the nails with aging. We have the effects of decreased vascular supply, the effects of diabetes, nutritional deficits, and so forth. So as a general rule, we inform the geriatric patient that their response will be slower. It has been emphasized repeatedly in medical and dermatologic literature that at-risk patients should be treated. Treatment being attempts to resolve or lessen the onychomycosis effects and not just debride the nail, although debridement is certainly important in preventing pressure, secondary bacterial infection, ulceration, and gangrene. So this is certainly not a trivial problem. The At-risk populations where we need to consider active treatment include the diabetic patient, patients with peripheral arterial disease, the increasingly confronted population of patients who are on immunosuppressive therapy for cancer, for inflammatory arthritic disorders, inflammatory bowel disease, and so forth, and patients who have lymphedema or chronic venous insufficiency with recurring episodes of cellulitis. These patients should be actively treated not only for their onychomycosis, but for interdigital infections and tinea pedis. And it's important that we communicate this to the patients. I think a lot of times compliance is really based upon effective education to the patient and their families, particularly the geriatric patient. Let them know that this is not a minor concern in the at-risk patient, and that we know that there is a wealth of literature that suggests onychomycosis needs to be appropriately treated. So we see patients such as this that have onychomycosis and poor foot hygiene, and this can result in gangrene and infection and loss of limb. Looking at this particular study of patients attending the Veterans Hospital in Seattle, Washington, onychomycosis and tinea pedis were two of the major factors associated with prediction of foot ulceration. Other studies have similarly shown that onychomycosis is associated with increased risk of infection and osteomyelitis. Looking at patients with foot ulceration, we know that abnormal toenail changes are present in 70% of these patients. And again, study demonstrating that fungal infection is a major risk factor for ulceration. Perhaps one of the most important studies was that of Jeffrey Robbins, published 13 years ago, looking at the increased incidence of onychomycosis in patients with foot infection, patients with gangrene, and patients with foot ulceration without gangrene. So onychomycosis is not a minor issue in the at-risk patient and really needs to be assessed and treated. And we've seen increasing calls in the literature suggesting that there is an association between onychomycosis and cellulitis, and calling for improved surveillance and treatment of tinea pedis and onychomycosis. And as podiatric physicians, we see these at-risk patients and should be actively treating these disorders. Now, we know that not everyone presenting with dystrophic or abnormal appearing nails has in fact onychomycosis. So from a practical standpoint, how much testing is enough? And the question is, are the changes that we're looking at representative of onychomycosis? And I might add as an aside, we also want to assess the patients for the possibility of concurrent interdigital or pedal tinea pedis. So a number of tests are available to us. I believe this would be representative of the most common testing available. Most podiatric physicians do not perform KOH studies. However, if you do, while KOH is helpful for demonstrating the presence of a fungus, it gives you no indication as to the speciation or viability. Therefore, while it is helpful in saying yes or no, there is a fungus present, it tells us nothing about the actual genus and species of the organism, and therefore it is not helpful for determining the appropriate therapy unless one works on the presumption that the majority of such infections are in fact dermatophytes. PAS studies are very cost effective. They have tremendous reliability in terms of false negatives. So a negative PAS study is a very helpful indicator that the nail changes are likely not onychomycosis associated. Now, the problem with the PAS is that while it is a sensitive test and extremely helpful, it gives us no information regarding speciation or the viability of the organism. So here again, it may not be helpful in determining the specific therapy to be administered unless, again, once assumed that it is likely tinea due to Trichophyton rubrum. Fungal cultures are certainly readily available. I think most people are familiar with the complications of fungal culture. First is that of obtaining a proper specimen. The second is the fact that there is a considerable false negative rate associated with fungal cultures, and therefore, if one is confronted with strong clinical evidence that there is in fact a fungal infection and the culture is negative, you have to consider additional testing. The advantage of a fungal culture is that when positive, it provides information regarding viability and speciation. Genetic testing and rapid genetic testing is helpful. It is sensitive. The question is whether or not the increased expense is justified. More recently, microscopy has been advocated for, or dermoscopy rather, has been advocated for evaluation of onychomycosis. There are characteristic presenting findings with the use of a dermatoscope that are suggested as being helpful in making the diagnosis of onychomycosis. The problem here, again, is one of speciation. So in looking at cost versus sensitivity, I think we have to take that into account so that while certain tests, such as molecular testing, are extremely sensitive, we also have considerable cost associated with that. Fungal cultures a bit less expensive. However, we do have the problem of false negative testing. PAS, reasonably priced test, and PAS associated with a fairly acceptable, very acceptable positive and false and negative rates to be considered. And again, microscopy increasingly being looked at as an alternative. So the question is, how much testing is required in treating onychomycosis in the elderly patient? And the question you need to ask yourself is, do I need to confirm simply that it is onychomycosis, or do you require identification of the genus and species? So if you merely need to know yes or no there is a fungus, then dermoscopy, PAS studies, KOH, or possibly even a good clinical examination is likely going to be sufficient. If you require identification of genus and species, then genetic testing, culture are going to be required. So when do you need to know this? Well, if you're going to be utilizing potentially dangerous medications for treating the onychomycosis, or if you're going to be using very expensive medications for the treatment of onychomycosis, you want to justify the risk, you want to justify the expense. So the question is, if you know it is a fungus, what are you going to do about it from a practical sense? So your clinical options are to treat empirically with topical or oral therapy, or to confirm the presence of onychomycosis within office testing, such as dermoscopy or a KOH. I don't think many people are doing dermatophyte test media testing any longer, but that's certainly an option. From a cost-effective standpoint, if you merely need to know whether it is a fungus and not necessarily the genus or species, then PAS studies are certainly worthy of consideration. If you're going to use an expensive medication or a medication with potential side effects systemically, then either culture or genetic testing is appropriate. The American Academy of Dermatology recommends confirmatory testing if you are considering either systemic therapy or expensive topical therapy. Now, looking at onychomycosis in the elderly patient, there are a variety of options that are available, and I suspect most of the listeners are familiar with the available therapies, and they range from no treatment to palliative care. Topical therapies of various types are available. Surgical therapy ranging from removal of the nails to removal of the nail and matrix for permanent removal. Systemic therapies are certainly available, and combination therapies. Looking at oral therapies for onychomycosis, there are a variety of agents that are typically employed, and I would venture to say that terbinafine, itraconazole, and fluconazole represent the overwhelming majority of oral agents that are utilized. Terbinafine and itraconazole are approved for the treatment of onychomycosis. As you will see, the literature indicates that these agents are well tolerated in the geriatric patient. Fluconazole is also available, although not approved, for the treatment of onychomycosis. One would consider oral therapies when there is disease involving the proximal nail plates, when there is involvement of multiple nails, and obviously when there is no contraindication, and when therapy is felt to be indicated. And again, we would consider this in the at-risk patient, the patient with diabetes, the patient with vascular disease, the patient with chronic venous insufficiency, the immunosuppressed patients, those patients with which onychomycosis is known to be associated with increased risk of cellulitis, ulceration, and serious lower limb pathology. So what is the reality of terbinafine and hepatocellular toxicity? The incidence has been probably greatly exaggerated. It's been estimated that hepatocellular toxicity will occur between 1 in 50,000 and 1 in 100,000 patients. It is very effective against dermatophytes, a few candida infections, not particularly effective against saprophytic fungi. You certainly want to think long and hard utilizing oral terbinafine therapy in patients who are high risk, meaning they have a history of hepatitis, alcohol abuse, or they're taking hepatotoxic drugs. And you want to balance the cost, which is relatively inexpensive, even with associated laboratory studies treating terbinafine, versus very expensive topical agents such as efinaconazole or tavabarol. So the oral therapies, we know the literature shows hepatocellular toxicity is very unlikely. If you are particularly concerned, you would obtain a CBC and liver function studies every 4 to 6 weeks, and the patients should be willing to undergo whatever laboratory studies you feel are appropriate at a frequency that you feel is appropriate. You may want to monitor renal function in addition. Now, the important thing, whether you're utilizing oral or topical therapy, is to emphasize to the patient that they're not going to see a change in the short term, so that the treatment of onychomycosis, as you know, as practitioners, is a long-term proposition. It's going to take many, many, many months to note a substantial improvement, and patients need to be educated regarding this so that their expectations are set and are realistic. In utilizing oral therapy or utilizing topical therapy, it's also important not only to explain to the patient the benefits and risks of therapy, but also to determine the endpoint for your treatment. Are you going to shoot for improvement but not cure? Are you going to go for clinical cure, meaning that the nail will look better but not necessarily have relief from the fungal infection? Are we going for a mycologic cure? Are we going for total cure, meaning we have removed the fungus with negative KOH and negative fungal cultures at some point together with restitution of a normal appearing nail. And then in the long term, the patient needs to participate in those activities appropriate to prevent a recurrence of the infection, in addition to which we want to prevent recurrence of local pathologies such as secondary bacterial infections and ulceration. Typically, therapy with terbinafine is 250 milligrams daily for 12 weeks. With itraconazole, pulse dosing represents itraconazole dosed as a pulse dose typically of 200 milligrams a day, dosed as a BID, 1 week off and 1 week on and 3 weeks off. So that typically itraconazole is pulse dosed for 3 months. When fluconazole is utilized, the dosage is recommended at 100 to 300 milligrams weekly for between 6 and 12 months. Both terbinafine and itraconazole have been shown to be effective in the treatment of onychomycosis in older patients, with a slightly lower cure rate in the elderly than in younger patients. Looking at oral therapies for the treatment of onychomycosis in the older patient, the highest cure rates are with terbinafine at 76%, pulse dose itraconazole 63%, fluconazole at about 48%, and the overall recurrence rates are reported anywhere from 10 to 53%. Terbinafine, as mentioned, is helpful for the treatment of dermatophytes and some yeasts and some non-dermatophyte molds. The dosage, again, is 250 milligrams a day for 12 weeks. Clinical cure averages in reports at about 66%, mycologic cure 76%. You have to be careful with the use of terbinafine in certain agents which are not uncommonly used in the elderly patient. This would include anticoagulants such as warfarin, serotonin, norepinephrine, reuptake inhibitors, tricyclic antidepressants, certain antiarrhythmic agents, and beta blockers, and you do want to check CBCs and hepatic and probably renal function. There are no specific studies on terbinafine and aging. The safety and efficacy in the older patient are not well established. However, studies have not demonstrated any age-related terbinafine-associated pathology. Again, because we're dealing with older patients, they're more likely to have some concurrent hepatic or renal or cardiac issue. Obviously, you don't give terbinafine to someone with known allergy, and as mentioned earlier, it's not given to patients with chronic hepatic disease. In addition to getting comparative studies of renal function and hepatic function while utilizing a course of oral terbinafine, you want to ask patients for the possibility of signs or symptoms of liver dysfunction, including nausea, vomiting, fatigue, anorexia, any right upper quadrant pain. Do you notice any sclerosis or rather sclericterus or jaundice? And I'll ask if there's any change in fecal or urine coloration and document that you are checking. Now, there have been serious cases of hepatocellular toxicity reported with the use of terbinafine, including liver failure and the need for liver transplant and death. The incidence is 1 in 50,000 at a high to 1 in 100,000 as a low. And the majority of these patients that did have serious side effects from the terbinafine also had rather significant comorbid conditions. Again, as I've mentioned, you want to be careful using terbinafine in the elderly patient. On beta blockers, those taking antiarrhythmic agents, those taking tricyclic antidepressants or selective serotonin, norepinephrine reuptake inhibitors. And one can certainly go to the literature and look at lists of drugs with which there can be some potential interaction with terbinafine. Now, the safety and efficacy of terbinafine has been looked at in a number of studies. This particular paper from Geriatric Pharmacotherapy looking at the use of both oral terbinafine with debridement for the treatment of onychomycosis. The average age of the patients in this study was just under 70 years of age. Adverse events occurred in 28%. Most often reported were nausea, sinusitis, arthralgia, elevated cholesterol, which again were not thought by the researchers to be related to the terbinafine. The conclusion of this study was that terbinafine is well tolerated in the elderly patient, and particularly well tolerated in patients with hypertension, diabetes, and dyslipidemia. The study also noted that the complete cure rate was higher when debridement was utilized with the oral terbinafine, and this is something to be discussed with the patients. Another study in the International Journal of Dermatology looked at the safety of terbinafine in patients over the age of 60, again concluding the drug to be safe and effective in the geriatric patient. Another study in drugs and aging looking at onychomycosis in the elderly patient, again showing that oral terbinafine is safe and effective in the geriatric patient. So looking at oral terbinafine in the elderly patient, it is something we probably underutilize. Obviously, judicious use, judicious selection of patients is important, but it is the drug of choice for dermatophyte infections. We've talked about the fact that there are certain patient subsets that are considered at-risk populations, and these patients should be actively treated, and most studies show that it is safe and effective in the elderly patient. Alternatives to daily terbinafine therapy include various pulse dose regimens, including, for example, 250 milligrams a day, 1 week on, 3 weeks off for 3 months, or the use of 500 milligrams daily, 1 week on, 3 weeks off for 3 to 4 months. And generally, pulse dosing has been shown to be effective, although slightly less so than daily dosing. And there are quite a number of studies that have looked at the use of terbinafine, both as a standard daily dosing regimen as well as in pulse dose, generally showing a successful outcome in the majority of patients being studied for onychomycosis. And again, looking in long term at 24 weeks, really no substantial difference in outcomes, particularly mycological cure and clinical cure between continuous and pulse dose terbinafine. So we know that some are more comfortable with pulse dosing. Fluconazole can also be utilized. Diflucan is given as a dose of 100 to 300 milligrams per week. In utilizing fluconazole for treatment of onychomycosis, prolonged therapy for as long as 12 months is required. The clinical cure rate, as you can see, is about 41%, mycological cure rate about 48%. You do want to be careful utilizing the drug with calcium channel blockers or statin drugs. Itraconazole, helpful for the treatment of dermatophytes, some non-dermatophyte molds, Aspergillus and Candida. The dosage is 200 milligrams twice daily for 7 days each month for a total of 3 months. Reasonable clinical cure rate of 63%, mycological cure rate slightly higher when it is administered as a continuous dosage rather than a pulse dose. In using itraconazole, there are a few more drug interactions than terbinafine, so one wants to obtain electrolytes, liver function studies, and renal function studies. You want to be careful utilizing itraconazole in patients taking proton pump inhibitors, statin drugs, warfarin, calcium channel blockers, and certainly consider seriously whether to employ the drug for patients with ventricular dysfunction or congestive heart failure. Looking at the recommendations of the British Association of Dermatologists, terbinafine is considered the first-line treatment for dermatophyte onychomycosis, obviously not to be used in patients with significant acute or chronic renal disease. Itraconazole is also considered an appropriate first-line treatment for dermatophyte onychomycosis, with fluconazole utilized primarily in patients unable to tolerate either terbinafine or itraconazole. Generally, it is the opinion of the British Association of Dermatologists that combination therapy is likely to be more effective than monotherapy, and it is generally recommended that griseofulvin no longer be utilized as a first-line choice. The American Academy of Dermatology and the American Board of Internal Medicine did cooperate in a Choosing Wisely initiative for the treatment of onychomycosis, and they caution against the use of oral agents such as itraconazole or terbinafine without first obtaining confirmatory testing. They note that about 50% of patients with suspected onychomycosis have an alternative diagnosis. Therefore, we want to eliminate the use of oral agents in patients that do not have onychomycosis. The use of confirmatory testing will eliminate a certain number of patients, reduce the number of adverse sequelae, therefore, and they recommend the use of PAS or fungal culture studies prior to the initiation of therapy. So looking at mycological cure rates and complete cure rates, terbinafine would seem to demonstrate the highest cure rates. Pulse-dose itraconazole next, and fluconazole the lowest number of successful treatment. Again, most of the literature is clear that compared to fluconazole and itraconazole, oral terbinafine offers the highest cure rates over time. So the average podiatrist in private practice is inundated with patients seeking cures for onychomycosis. What about topical treatment of onychomycosis? Well, it's not practical for many of our elderly patients. They simply cannot bend down. They can't apply the medication. They don't have perhaps a partner or someone to assist them in application of the medication. If we look at the data available for the use of topicals for the treatment of onychomycosis, number one, we generally have to have less than 50% involvement of the nail plates. Many of these agents are expensive. Because they are so expensive, confirmatory testing is generally recommended. We can spend thousands of dollars in topical therapy. The patients need to understand that a long duration of treatment and many months of cooperation on their part is going to be required, so that compliance is an issue. And for many patients, particularly those with marked hypertrophy and dystrophy, debridement is still going to be required. I think to some extent there's been a large amount of corporate influence with regard to decision making for the use of topical therapies. Many of the companies that manufacture topical agents have become major sponsors for seminars, for well-appointed dinners with thought leaders advocating the use of these agents. And I think there's been a failure to recognize the fact that these agents are only effective and have only been studied under limited circumstances. Less than 50% of the nail plate without marked dystrophy. These agents are expensive and really have never been tested or used for the average patients that we have all seen in everyday private practice. There is a tremendous market out there for the treatment of onychomycosis. Many of the patients receive just debridement, and there's still only a minority of patients that receive either topical therapy or oral therapy, with almost half the patients with onychomycosis being untreated. The amount of money that is being made for the treatment of onychomycosis with topical agents is just tremendous. And we're talking about an awful lot of money here, so why not a free dinner? Why not pay a thought leader or speaker to attempt to induce you to utilize these agents? And the question really is, how effective are they? The topical therapies require less than 50% of the nail plate to be involved. You need to know if you have a susceptible organism, because the topical agents are not broad spectrum and really generally have only been approved for the treatment of dermatophytes, particularly T. rubrum. Does the patient want to go to the expense and inconvenience of treatment? Because the treatment is going to result in an expenditure of thousands and thousands of dollars, the question is, who's going to pay for the medication? You want to make sure they have no allergies or contraindication to the topical therapy. And then the question is, what are you going to do to reduce recurrence of the onychomycosis? A number of topical therapies are available, and this list is certainly not all inclusive, and we want to consider some of the more common ones. Cyclopirox has been around quite some time. We have had various thought leaders have companies treat us to dinners and seminar sponsorships and tell us to utilize this agent. You have to have involvement of less than 50% of the nail plate, and it must be the distal 50%. It's effective only for dermatophytes and some candida species. It has very low efficacy as monotherapy, as you could see. A clinical cure rate less than 10%, a mycologic cure rate of less than, on average, 1/3, although the cure rates are significantly improved in combination with debridement. 48 weeks of therapy are required. It's been shown to be effective in combination with oral therapy, and it has been utilized for prophylaxis to prevent recurrence. Tavabarol has also been advocated, and we've certainly had no shortage of speakers and thought leaders sponsored by the manufacturers of this product. It has been shown to be effective for T. rubrum and T. mentagrophytes. It's applied once a week for 48 weeks. But again, if we look at a complete cure achieved, both clinical and mycologic cure, you could see the numbers are extremely low. Similarly, efinaconazole, they have successfully marketed this, the podiatric profession. But here again, while the mycologic cure rate is been reported in 2 studies, between 53 and 55% complete cure rates, meaning resolution of the mycotic changes and resolution of the actual infection, as you could see, are extremely low after 48 weeks. Looking at the topicals available, of the available topicals, the mycologic cure rate seems to be highest with efinaconazole and cyclopirox and tavabarol being about equal for mycologic cure rate. But I would ask you to look at the complete cure rates. And here again, you could see these are extremely, extremely low numbers. And the question is, subjecting a patient to thousands of dollars of drug expense, 8 months of therapy, and achieving complete cure in very few patients. So we have to really look at the cure rate versus the cost of therapy and whether or not we can justify the significant expense of the newer topical therapies for the complete cure of onychomycosis. Other topical agents include the use of urea with and without occlusion. Urea destroys the keratin and the diseased nail bed bonding. It allows a chemical avulsion of the nail, following which you can then utilize a topical antifungal. A variety of urea compounds are available. It's been shown that the combination of cyclopirox and urea is more effective than cyclopirox alone. Urea has also been used in combination with tolnaftate under an occlusive dressing. Again, what's nice about urea is it softens the nail and causes an onychomalacia. It separates the attachment of the nail plate and nail bed. It allows a very aggressive, pain-free debridement of the nail and a very substantial response to treatment with urea with tolnaftate has been reported. One can also utilize urea as a compound. I have done this for many years, utilizing a base of 40% urea. One can add to that the preferred topical antifungal of choice. Additionally, if one's going to utilize an azole antifungal, ibuprofen can be added. It's been shown to work synergistically with azole antifungals. Salicylic acid can be compounded also, as can tea tree oil. So typically for compounding, one would utilize a base of urea together with something such as terbinafine or itraconazole or amphotericin B and some ibuprofen. My personal topical preference, which is more effective in my opinion and less expensive than alternatives, is to utilize a compounded combination of amphotericin B together with terbinafine, urea, and thymol. This creates a good deal of onychomalacia, and it is very, very effective for the treatment of onychomycosis. Topical tolnaftate has been advocated as a 1% agent, and this is available as in a variety of over-the-counter products. Undasolinic acid is available in a variety of topicals. Again, both are primarily over-the-counter agents, and some patients will respond to that. Cyclopirox and terbinafine in combination therapy have been shown to have a complete cure rate of 68% and a mycologic cure rate of 88%. So this combination can be helpful. A number of alternative therapies are available, such as laser therapy, photodynamic therapy, chemical nail ablation, primarily utilizing urea or urea and salicylic acid, and of course surgical nail removal. In utilizing urea, as mentioned, the patient needs to understand that your nails will be loosened. We will go ahead and obtain a culture or PAS. We will start urea application nightly under occlusion. We will evaluate the patient at 1 month, remove as much of the nail as possible, or chemically avulse almost the entire nail, following which we then initiate appropriate topical or oral therapy and treat for a minimum of 6 months. Vicks VapoRub has offered a inexpensive alternative for the treatment of onychomycosis. Obviously, the medication was not intended for use, but interestingly enough, mycologic and clinical cure rates of 28% have been reported, and over half patients that utilize Vicks VapoRub do develop a partial clearing of their onychomycosis. Other agents that have been reported for use in onychomycosis include tea tree oil, although multiple studies seem to indicate it really has little benefit for the treatment of onychomycosis. Snake root extract has been reported as having a clinical cure rate of 71% and a mycologic cure rate of 59%. Other agents such as renewed nail with a 50% mycological cure rate. Debridement has been shown to be helpful in association with oral terbinafine as well as cyclopirox, and the addition of debridement with topical cyclopirox or oral terbinafine has been shown to be associated with an increased cure rate. We've seen advocacy for the use of lasers. If we look at the actual literature, we see that the mycologic cure rates for lasers average just over 1 in 10 patients, clinical cure about 13%, clinical improvement, however, 1/3 to 2/3 of patients. Looking at FDA reviews of lasers for the treatment of onychomycosis, the lasers are helpful for improving the appearance of the nails. They do not meet endpoints for medical improvement, and they are not superior to alternative therapies. Now, the issue with a laser relates in part to at-risk patients. We know that patients with diabetes, patients with peripheral arterial disease, patients with chronic venous insufficiency, immunosuppressed patients, and so forth, are at increased risk for pathology due to onychomycosis. These are patients in whom onychomycosis needs to be treated. And the problem is that although lasers make the nail appear healthier, they do not treat the actual fungus. So when we utilize a laser in the at-risk population, we are denying that patient actual treatment. In addition, at-risk patients may be at higher risk for injury from the laser, and therefore lasers are not recommended in populations that require actual treatment for onychomycosis, because the data does not support the use of lasers for these populations. If we look at the FDA recommended labeling with regard to lasers and onychomycosis, they are clear that lasers are indicated for a temporary increase in clear nail in patients with onychomycosis only when used together with topical antifungal products. It is noted that these devices, meaning lasers, should be used with caution in patients with diabetes, peripheral arterial disease, immunosuppression, or any other medical state which warrants definitive antifungal therapy. In looking at practical issues in treating patients with lasers, we also want to recall that a substantial portion of patients that appear to have onychomycosis do not actually have onychomycosis. Lasers are not species specific. Therefore, if one is going to treat fungal toenails only with a laser and no concurrent therapy, there's really no point in obtaining a culture or PAS, or rather genetic testing, because it doesn't matter what species is present. The laser is not species specific. So the question of confirmatory testing for a laser is probably answered by saying either KOH or PAS is sufficient, perhaps dermoscopy. You want to remember that the treatment of a nail with a laser and improvement in the appearance of the nail does not mean that the fungus is actually being treated. You want to also recall that if there is a secondary issue such as repetitive mechanical trauma, the lasers will not be of much help. As far as relapse goes in the elderly patients, we want to concurrently identify and treat tinea pedis. We want to look for the presence of repetitive trauma to the nail, and PAS and histology certainly helpful in that regard. We want to consider the possibility of environmental exposure to fungal organisms and reinfection. We know that some patients are genetically predisposed to fungal infection. We know that response will be slower because of age or the presence of peripheral arterial disease or immunosuppression. So in trying to prevent recurrence, you want to concurrently treat the tinea pedis. You want to continue with preventive topical therapy once the initial infection has been cured. You want to reduce microtrauma and perhaps recommend changes in footwear or shoe disinfection. You may want to recommend not exposing the foot to those environmental circumstances that led to acquisition of the infection to begin with, and you want to recommend periodic clean nail debridement. The economic considerations with regard to onychomycosis can range from non-covered debridement to covered debridement, nail avulsions, nail removal with excision of the matrix, office visits in treating the patient medically, various in-office therapies that are available, and obviously products that are sold for the treatment of onychomycosis. So in summary, the treatment for options for the geriatric patient range from no treatment to palliative care to topical therapies and surgical therapies to systemic therapies or combination therapies. So we know that this is a problem that is common in the geriatric patient. It is a problem with which the podiatrist is frequently confronted. It does warrant treatment. We know that the majority of patients with onychomycosis either receive no treatment or receive only palliative care. And we know that at-risk populations, including the at-risk populations in the geriatric patient population, require more aggressive therapy. So hopefully you will give some thought to more effective and aggressive treatment of onychomycosis in the geriatric patient. It is indicated, it is warranted, and it is needed. Thank you.